But I wanted to point out when you do this objective, specific questions you have to ask for the goal. Okay. So when and how did the moon begin? Do they know? Okay. Did it start suddenly, or did it start insidiously or on its own? Or do they have no idea? It just showed up today. Okay. But you are going to give me a heart attack. You go over there, please, so you don't get hurt. He's the one who wants to be a pilot.
Oh.
Well, and zoologist, sorry, my bad. And the marine biologist. If you really want to have fun during break, you can ask them any fact about animals. They can probably name you the Latin name and everything associated with the animal. Okay. Yeah. And they correct your teachers, which is good, so I can find it out. Okay, are there any precipitating events that was associated with the onset of the moon? So, did they have an extreme fever? Did they get in a car wreck? Did they hit their leg on the outside of the door and they came through the door? Was there an animal bite, an insect bite, or did they see what did them, or did they just fall asleep after they can't think and they woke up with this huge bite in their teeth on their arm? Was there a strike? Was there a medical event? Were they walking, etc.? You get the picture, right? Yeah. Okay. What are they currently doing for the moon? The most typical thing I ever heard was I'm using bourbon on it every day. Bourbon. Well, it's a good antiseptic. Did they do anything? Have they ever had this going before? Or is this the first time ever that they've had it? If you want to cheer, there's cheers. If you want to spot over there, you're welcome to join. But I don't know what you want to get So is there any previous treatment for the moon? Okay, so have they had Have they had a gap? That's not what this was supposed to look like. Please don't do that. Good behavior, remember? Best behavior ever in your life.
I think we remember that.
Who and what healthcare providers are involved in the current behavior? Who are they seeing? Who's the prescribing physician? Are they seeing a dermatologist? Are they seeing a physician? Are they seeing vascular? Are they seeing a primary? Who is their primary person for them? What was the history? If they had wounds, what happened? How long did it take them? How long were they there? What worked? What didn't work? Did they have to have skin grafts, etc.? What did they like? What didn't they like about the treatment that they received? Okay. And then what symptoms do they have right now specific to the wound? So besides pain, right? Are they having any itching? Are they having fever? Does it feel hot? Is it swollen? Is it painful? And again, with pain, now with the pain screen, we're pretty good at asking what's your level of pain, what's the aggravating factors, what's the relieving factors. For wounds, you want to know, does the pain wake them up at night? Does the pain change with ambulation? Distance. Ambulation. Does the pain get better with elevation? Does the pain get better with dependency, hanging their leg on the side of the bed? Do they have to sleep with their legs dangling down? All of these things will cue you into specific etiologies which come later. How this course is arranged is you teach you the general basics of the valve, and then you go into the nitty-gritty for the etiology and how you do differential diagnosis, and then we do interventions. Okay? We do general interventions, we do differential diagnosis, and we do specific interventions. And is there any waxing or banging? Okay. Is the wound, since it started, is it improving? Is it regressing? Is it just hanging out? I think I can tell you that if they've seen it. If they've had the audacity to look at it. Some people do not look at it, and they have a bad look at it. Some people can't physically see it because it's on their backside somewhere and they can't see it. And they have a thought when a mirror behind it, you can see it. Okay. What other disease processes do they have, right? So cast medical history, cast all those things are going to But here's another one, energy. What medical tests have they had that are specific to people? Have they had a CT scan or an MRI or an X-ray? Have they had an angiogram? Have they had different mappings of their veins and arteries and veins out? Okay. What are their labs? Yes. Yeah. So if there's a clinical, if they have, they're looking to see if there's a bone infection, present of bone. And if there's bone exposed in the bone, you'll typically see a X-ray order initially, and then you'll see the bone scanner come out, but they usually order an X-ray first. You may also see MRI or CT scan ordered for the same thing. You may also see MRI, CT scan based on the same plastic image. So there's different reasons, but it's basically a differential diagnosis to make sure there's no, if it's osteo and you're missing osteo, osteoarthritis. The labs and nutritional status. That's its own lecture. And we're going to go through all the nutrition and all the labs. Because the labs for this part, this is probably the first time you're going to get an in-depth lab analysis. But you need to know what's good or what's not good in your labs, because it'll help guide you down the way. You also need to know the nutrition and hydration. If they don't have good nutrition or hydration, there's no way you're going to do it. What is it? We're better at it now, but we're not really as good. Here's the other thing. What meds are they taking? Because there's meds that specifically block fibroblastic activity. So they block fibroblastic activity. You're out of luck for the proliferation of remodeling. It's not going to happen. Like if they're immunosuppressed, you can't take them off of immunosuppressant, but it's going to really make that inflammation process not very effective. So there can be some really big challenges with that. Also, herbs. What herbs and home remedies are they doing? There's some major key players that interact with some of these drugs and some of the cells in the wound. So, as a general, I wrote down some of the big names here, so you can keep them on your screen list. And if you don't remember what some of them are, go back to our college. And some of them are just listed because it's, well, it would be like if you're on one of the antibiotics, so why are you on it? How long have you been on it? Do you have an active infection? Is it actually treating what it's supposed to be treating? Or is it for a totally different infection that I don't know about? Okay. What allergies do they have? We have a lot of different allergies that could be in the dressings that we use, in the gloves that we use, in the medications or salves we add on. We've gotten much better compared to when I started practicing to now. Almost everything is latex free. They've done a really good job of getting rid of a lot of the allergens, but you can still have allergies. So, do they have any medication allergies? Allergies to adhesives, latex, etc. Do they have an extreme diet? And if they do, how long have they been? If they grew up vegan, they have a very different way of controlling their diet, and their body's pretty good. At least from my experience, most people who grew up vegan, they have really great control of their diet and what they can. But if they just decided to join the bandwagon and haven't quite figured out how it all works yet, that's the damage. Because your body's been used to eating everything versus only eating certain things. Does that make sense? So it's not so much of those things. There's also some different festivals, some religious fasting, depending on what religion you want. So you need to know those things. Also, what kind of social history? That's nothing new, right? What's your employment status? What's your functional life at home? Who lives with you? Can they perform the dressing damage, dressing change? Or do you have to keep so much space? That's the biggest thing you want to know. Do they drive or take public transportation? What's their job look like? All other stuff you can ask. What's their lifestyle like? Do they have any assistive devices? What shoes do they wear? Do they have any orthotics and prosthetics? If those are not routine questions right now in their exam, they need to be, especially for this. Okay, and then all this other stuff, Okay. Chart reviews. If you're in the hospital side, you can get all your information from the chart review, and then all you're doing is confirming stuff on your account, which is very delightful. You know their history, you blood flow gives you all kinds of things. In particular, these are the different things that you need specific to the wounds. I wrote them all on here for you. But now here's the red flag things you want to watch out for. Okay. And these are signs where sometimes you see these in the hospital, you're doing a bedside consult, or even outpatient consult. If you see just erythema, edema, deep pain, and hot skin, you have to make sure it's not necrotizing fasciitis or cellulitis. Those are fleas. Have you heard of that rash? Because we'll talk about it this semester. It comes later. Okay. You want to make sure if they're short and back and have low extremities, you know, that they're not going to just percolate. That is not just another system disease. If they are having chest pain, of course, are they having an acute MI? If they're having rash, itchy, edema, and shortness of breath, did they just start medication and I'm having an allergic reaction? I've caught two of them in my career. One outpatient wise, one inpatient wise. The outpatient one, they went to the ER. ER said, it's fine. It's just, you're healing. Came up to the appointment at me, and I called everybody. And the good thing was that we stopped med, but they had to get admitted and had to get a drug reversal because it started to affect all their organs. So you have to just make sure you're walking around it. If there's blisters and pain in a dermatome, make sure it's not shingles. Okay, or if someone just has a spread of blisters, what's going on? Because that's the typical presentation. And if there's a dark mole with asymmetry and uneven borders, you have to make sure it's not cancer. So there's a lot of things that are in there. And then there's more, and the list goes on. Is it not an infection? Is it PAD? Are you sure it's not? This one's big. Bleeding that's not controlled by pressure that keeps pumping out. Have you ever seen an arterial bleed live? Okay. So normally, if I put compression on somebody and I hold something for a while, how long does it take for me to thaw in a, how many minutes? 1 to 5, right? Okay. By the time I actually release the pressure, it should take 5 to 10 minutes to hold. If I release the pressure at 10 minutes and it's still gushing, that's a problem. Arterial bleeds also gush through the bandages in there. So if it's a true arterial bleed, it's going to pump out with every single beat of the heart. And so when you've got, usually if there's a bleed, you stack gauze and you put pressure on. You don't take that gauze off and put more on, you keep adding it on. And if the blood is keep popping up through there, you start to call it because it's arterial. I've seen a couple of arterial bleeds with back removals and other ones from patient injury. So they can happen, and when you do see them, you never forget them. If there's a new onset of a bruise with no recollection of a bruise happening to the area, okay, it could be the first sign of an arterial lesion and possibly a PE. Okay, if you probe to the bone, you have to always ask yourself, so probe to the bone means that in our assessment, we usually take a metal stake and we touch the inside of the wound bed, and then you hit something hard, that would be a bone. If you hit bone, should it be there or should it not be there? So sometimes you do a surgical debridement in pain wound, and so you expect to see bone and muscle when you take off the bandage. Other times, there was nothing done at all, so you hit the bone. If you unexpectedly hit the bone, you have to make sure it's not osteomyelitis. And most of the time when I've seen probed bone, and 90% of the time, it's always been covered. So, make sure that before you start, you have a good patient positioning, your lighting, your briefing, and you have all of your care and everything up. You don't want to have crazy hair that goes on. I used to always have hair that I had hair that was this long when I started practicing, and I used to have it down at work. And one of the first wounded guys I had, I tipped my head down and I came up, and it was ridiculous.
No.
Ever since then, never again. I had a ton and everything else in my hair and surgical guard. Here's my theme of this semester. Just don't look at the whole person. Okay? You got it? Because a lot of times we zoom in, once we see the gory, graphic wound, We forget about everything else. And everything else you already know how to treat, or you're learning how to treat. Okay. So you're going to screen all the systems. And if you need a reminder of what you should be looking with all the screens, it's all there. Okay. One thing that I don't know if we're programmed to do, you need to check IOs, so ins and outs. Are they using the bathroom okay? Are they not using it okay? Because if the wound is anywhere in their proximity, you need to know if they're continent only. That's going to impact your outcomes. Okay, same with their nutrition level and BMI. We'll get more into that. But now we're just going to hone into the looking at the wound. So before you look at the wound, you take off everything. So I put on gloves, I take off the dressing, I get rid of my gloves, I put on the new gloves. Then I clean the wound with saline. Then I can evaluate. But I just don't pull it off and start assessing with coloration and everything else. Because some dressings have residue and a smelly odor associated with it.
Sure. I'll
You
take
need to
some.
flush it out and clean it and really make sure that you're seeing what you're actually seeing. Okay, so if you want pictures of how you should do, if you want a video, this is the time frame, and this is the closest one I could find to how we eval. Okay. Make sure that if you're going to clean the wound, you should not be cleaning it with anything that's cytotoxic to the cells. Hydrogen peroxide, iodine, all the other things that we use for surgical cups. The reason why they're used for surgical cup treatment is because they kill everything. All the bad and all the good, they kill it all. You don't want to pour something that kills everything on the wound because it'll kill all the good and all the bad cells as well as all the good and bad bacteria. Yeah. Saline is the best because it's the same level of pH balance. The next thing would be tap water. If you don't have terrible tap water, which is unstable in nature. The next thing would be they do have spray cleansers in a bottle that you may see bedside. Those you have to be careful with because some you may use in deep cavities and some you may not. Generally speaking, if things are stuck, especially with little ones, you soak them in the bathtub and have them play with something else while they're there. Or a big whirlpool, something like that to get it loosened. Okay? And if it's truly stuck, that's a whole other discussion. But the irrigation not only does it cleanse it, but it also gets rid of the bacteria that will activate dressing residue. It's technically not a modality. Some people say wound irrigation alone is a modality. It's not. It's good. It's basically the standard of care. And irrigation is yeah. You take a bottle of saline, you go. And what I do is I start here and I would actually circle out in the wound. If it is a leg wound, I start at the top and I go down. So that way it's going down. I'm dripping the water down. And then when I go to take some gauze, I have it. Add it. Have it. Here. Then I'm going to go wipe the wound, but what I don't do is this. Because now I took all the stuff from my skin and threw it into the clean wound that I just cleansed. So what I would do is I would take a clean gauze, I would start from the center and wipe out from the wound. You get rid of that one, you get another one, and then you use this one to wipe away out the way. And that's standard for just about every single type of wound that exists. However, sometimes you can't do that because especially here on women, very hard. Because you can't, unless you can get in a stand like this, and most of the time when they have really bad back or other things over here, they're too sick and they usually not see it. So sometimes your cleaning is limited, but you do other things in your therapy to make up for it. Okay. Here's just do's and don'ts for you. And the specific procedure is all right now. Okay, so number one, when you do an eval, how many wounds do they have? Do they have one or do they have 37? 42 was my highest in one patient. 42 wounds, and they were still alive. What shape are they? Because the shape will also lend to etiology of the wound. Okay, where's the location and not the butt? The anatomical location. So when I pick up as the next treating therapist, I can say, oh, it's the right ischial tuberosity. Oh, it's the right greater trochanter. Okay. So these are just more of my P's to use the right term. The next part is the wound measurement. The wound measurement is probably one of the most confusing things. Okay. You always have to document the wound in length times width times depth. And it's always in centimeters. And it's always recorded in this order. Length, width times depth is centimeters. Length and width are perpendicular to each other. So I usually go, I usually take the edge of the wound here, and I go all the way here. So we have a bunch of ways to measure this. They have really cool grids. And they come in all sizes. I only have a few to show you. This is the small one. This is the diameter that you can use. This is inches, this one is centimeters. Okay. So that's how that one looks. Then you have a bigger version. The centimeters and this one are on the side. Okay. Yeah, notice they're all see-through, right? So I can put it right on top of the wound. Some people trace them out. We'll show you about that. And then they put this. There is specific dressing, tracing sheets you can get. One side is a sheet that pulls off and sticks to the medical record. One side is one that you discard because you don't want your germs to be able to pull up, right? Then we have guys like this, guys like this, right? So there's all kinds of different rules. When you do your worksheet, number one, you're gonna need this. Everyone needs to take one of these home with them. Otherwise, you can't do the worksheet. Okay. So what I'm going to do is I'm going to take my long measurement, right? If this is the wound, and this is going to be my length, and this is going to be my width. I'm going to start from the very top of the open skin here, and I'm going to go along here. And then ideally, I would have another one that I would put here, so I can get the full length, or you mark it, you move it, and then you measure the rest of it. And then I do the same thing for width. They're at a 90-degree angle. Normally, the head of the body is 12 o'clock, and my feet are at 6 o'clock. So I'm always usually measuring my length and aligning my length with the 12 to 6 position on the body. That is not always how it has to be. Sometimes the wound is really long one way and really short the other way. And so my length to be 2 centimeters and my width to be 15 and a half doesn't really make a lot of sense to me. So you can change your framework and say, okay, well, let's say that this is actually the head of the body. So now my length would be here at 12 o'clock, and this would be 6 o'clock. And this would now become length, and this would become width. How do I document it though? Well, I would say patient in this position, okay? And I measured, if it just says length times width times that, you assume it's 12 to 6 position. You don't have to document that. If you change the orientation, you do. And on some of the wound photographs that I have, I'm going to have you practice how you change the orientation of them. And you would say, length measured at 2 o'clock, which means that I started here on this angle, right? Instead of at here at 12 o'clock. You with me? Okay. So that's length and width. Okay, so here's the 12, and here's the 6. And then here's a picture of how you apply it. Now, to measure depth, what I'm going to do is I'm going to use Q-tips. Okay. And what I would do is there's 2 ways. I can either flip this into the max. I would go along the base of the wound, like this, and see where is the maximum amount of depth that I have. So let's say it's here. Then I have a choice of either putting my finger here, lifting it, and then putting it up to a grid sheet like this, okay, to measure it, or I have a choice of putting this in and then putting this in and then holding it. But look at this. Is that accurate for this patient? No. So you can see how sometimes one method works versus the other method. Because if I'm on the skin line like this, this looks like I have a 4.5 centimeter wound. But it's only 0.5 centimeters. So that's drastically different in terms of depth. So that's how I'm measuring it. Then I would pull it out like this. This is a cross method, and then I would measure this way. Sometimes when you work with a tech, I train them very well, so that way I mark it, and then I hand it to them to do all the measurements and recording. Just depends where you're at. I did that routinely when I worked full time. I don't do it anymore. I do all my own measurements. Okay, the tracing, I need to quantify on my eval the wound. And you can either use a tracing to do it, or you can take a photograph. Photographs, if you use a photograph, then you need to have a consent sign, and you need to make sure it's in alignment with whatever facility you're at and their policies and procedures. Okay. The facility I worked at full time, they did not allow photographs. We're not allowed. It used to be allowed, and then they stopped being allowed. If you do, when you do take a photograph, you have to make sure that you have a special, like if this was my camera, there's wound care cameras that we have, and they're set with a distance on a centimeter. So you would always take it at the same distance from the wound. And inside of there, I would have one of these guys with the date and the patient's initial, their medical record number in the photograph. What does that do?
Make sure it doesn't get misplaced.
Doesn't let you misplace it, but more importantly, doesn't let you distort it. If it's embedded in the photo, it's much harder to get rid of than if it was never embedded in the photo. Because I can take the same picture, blow it up really bad in a courtroom, and make it look enormous, and it was only this big. Right? It was only a little tiny dot instead of the whole body. Okay. If you use the tracing method, then what you do is you take this with this, let's just say this is the right shape. I would put the disposable side down. I would take a marker and outline the outside of it, and you pull it off, and you put this into the marker. Then some people go ahead with the tracing, and it will actually draw out on here what type of tissue is present where. Okay. But this is quantifiable, and when I tell the patient that your wound was 4.5 by 5.5, and now 3.5 by 2, they don't care about that, but if they show that it was this big and now it's this big, they see the difference. Okay. Same with photographs. I used to like to take photographs not for the medical record, but just to show my patients' problems, to show them personally. Okay. So if you do the tracing, then there's the parameters of that. And you're supposed to, and you can also see out here how you measured it, like length or width, etc. Yeah.
Looks like it, but are you supposed to get the August 9th part?
Yes.
So that determines then where the 2 o'clock or like 11 o'clock.
Yeah. Here's all the rules for digital photographs. Okay. Then you can also do a lot of fancy stuff which we don't have, which they do for research with different computer programs. So that's all in the computer about. Okay. They also do volumetric measurements. That's the most accurate, but that involves molding the wound and then pulling out the target and the wound. So you can imagine the results of the direct measurements and tracings absolutely should always be used to document your wounds. That is the standard of care. Photographs are not the standard of care. They're complementary, they're supplementary, but they're not the standard. Okay. So, let's do something here. So, what I have here are these different grid sheets. And then what I have here are some different wound photos from different patients. So take some. Is I tell them I'm going to be incredibly close to them. I'm going to touch their wound. I'm going to feel inside of it, and I need them to tell me what's going on. If they feel anything if we don't. Okay. So before I go in and start doing any kind of depth assessment, I physically have on gloves and gown, and I will go in and I will feel all around with my hands and feel the anatomy and figure out what structures are there ahead of time. Then I introduce and try to measure. Then what I usually have, and I forgot it, you know the vibrator tuning forks? I have a long metal pod like that, and you use the metal pod to see if there's any bone or any other solid structures underneath as you're tapping. If you tap and hit bone, there's an automatic red flag that flies in my head, unless it's a post-surgical, or if it's an amputation that was just completed. Because in amputations, you're going to see really great anatomy. And so I expect to see, in surgical procedures and other things, I expect to see those really big landmarks. Then I go in and I measure depth. The depth, I had a really good question. You don't have to mark clear if the wound was it. You just have to measure the deepest part. That rule changes when we get to these other things that I have to measure. There's the other cavities in the wound that exist, which are on the screen. Undermining, tunneling, sinus tracts, fistulas. Do you know what they are? Do you know what a fistula is?
Connects to, works together.
Okay. So,
The dialysis fistula?
no. So they are all considered subcutaneous extensions, okay? And if you assess them and find them, you need to document their presence and measure them respectively. Okay? What you need to do is examine with their quote. Generally speaking, most people use Q-tips. I will caution you about which edge are you going to use. Q-tips are made of wood. Wood can split and be left in the book. There's the lawsuits because of it. The other part is Q-tip edge. Q-tips are furry. And when you make them wet, they leave little glue behind, just like bugs. So, even though their Q-tips are generally what's available, some people also have sterile tools that they use to palpate. The problem is these are a lot more comfortable. Who wants a piece of long, cold, wet metal to go in versus something that's warm, right? So the temperature change can kind of change. What you want to do is the best thing is to have a calcium alginate tip. Q-tip, most places don't stock them because they're really expensive, and these you can get $1,000 in a box for the same price as one of those. So that's how you use them. Undermining is this is what happens in undermining here. It occurs when a tissue edge erodes, leaving a large wound with a small opening. So undermining, everyone take your hand, stick it underneath your sleeve, and roll your fingers in. See how I can see my handprint going underneath my sleeve? Okay. Along the wound edge is typically when you find them, and it's from erosion underneath it. It's typically attributed to pressure injuries. You don't need to write any of that down because it's all in another lecture. Okay. So really, I really want you to do a lot of listening and learning, and just, it's all there. Everything's in the slides. Okay. So on this one, unfortunately, I can't simulate very well, but when you get a chance, you want to come up here and kind of feel underneath here. I used to have a clay model for a throat last year, and I have to make another one. There's a way you can actually craft it. So I crafted a balloon model which had undermining and tunnels, which really kind of felt like how it felt. So undermining occurs here. It's a result of necrotic hypodermal contamination. So at the end of the day, you have a little hole, and actually the hole is actually this much bigger underneath it because the top layer of skin is usually here. What do you do for it? You typically have to surgically excise that tissue because you need clean, even wound edges for the wound to heal. So even though the wound was this big, it may now be this big if they go through a surgical incision. How do you measure it? You typically find the deepest aspect, put it up here, pull it out, and then you measure it against the grid. Okay? What I would do in order of documenting where the undermining is, I would say undermining began at 4 o'clock and ended at 5:30, with a deepest aspect being 4.2 centimeters. Understand? Bless you, bless you. Tunneling is when you actually have a narrow passage all the way through. My most favorite picture of this is this one. Two different wounds, and then wouldn't you know, they're connected. This is left over. This is from a huge abscess that was present. These were two wounds, two pressure ulcers on the ischial tuberosity and sacrum. Had a huge infection, and then the sinus tract formed between them, and then this was what resulted. The other time I've seen a lot of extensive undermining has been with this one, which is from the fistula removal. Okay, the tunneling is basically, can be a narrow connective passageway between two ways, or it can be a very specific hole that feels like that, all the way down. Okay? It's usually unidirectional, only goes one way, it doesn't fan out. So if I have tunneling present, I would say tunneling present at 5:30 o'clock of 7.2 centimeters. I would measure the depth of it. And there's a better picture of what the tunnel looks like. And then you have sinus tracts, and sinus tracts is when you have basically an acute infection that starts down here and then busts through the skin. So it looks like an hourglass. You have a little tiny opening, and it turns into a big bell. Okay. And it also has extension. And there's usually a much bigger bell bottom of where the sinus tract was. What happened was that some kind of infection occurred. Pus filled there, sat there until the pressure of the pus got too much, and then it found its way out of the skin. Okay. And then you've got fistulas. Fistulas are abnormal passageways between two or more body organ spaces. And so they name them for the organs that are involved. Enterocutaneous fistula, what does that mean? Intestine through the fat. Okay, fistula. A fistula, when visible, produces a very different drainage that looks like that discoloration. Can you see it? Can you see that funky color? Okay. It also bubbles. And with every bowel movement of the peristalsis of the intestines, as the peristalsis moves, things shoot out of it, like a bubble. They're my least favorite of all the three. If you want to see what the fistula mouth looks like up close and personal, there's a picture right here if you want to see it. I'm not going to pass it around, some people don't want to take that personal. This is the mouth of the intestine. Yeah. Yeah, right here. The intestine, this is the intestine right here. And the fistula is the opening where it's walking around it. So this is just a big summary slide in case you want to get everything else. Undermining, fistula, tunnel, sinus tract. Yeah.
Are these wounds usually painful, or does it get to a certain point where it's like, to get to this point, is there no?
Well, usually the deeper you go, the less pain you have.
So, you know,
No, I'm very gentle. Usually most people are very gentle, and you get a good hang of how much that person feels, especially the first time I see them. My exam is much, much different versus when I've been seeing them for a year and a half. And I know exactly what hurts and what doesn't. Shallower wounds with the epidermis and dermis intact, are very painful. They're probably the most painful. Wounds that break the plane of the dermis and have all the nociceptors removed with them, because that's where all your sensory receptors are, generally don't hurt as much. But it doesn't mean you can't tick off another nociceptor on one of the other structures that are exposed. So everyone has a very different tolerance of what pain is.
I was trying to think because, like, doing the undermining is like, that was very
No, not too much. So I gave you some documentation examples. Okay, so now, are we okay, or do we need another minute? Want to just keep going for tissue types? Okay, so now we look at the dimensions. Now we're done measuring them all. Now we say, what tissue is exposed? and this is when we get to estimate in our best abilities 100% of this one. So 100% of this, what I typically do is I take the blue, I divide it into 4 quarters, and I say, what color is this? Okay. What color is that? What color is this? What color is this? Right. So it's 100%. Good. Is that hard? That's all it is. Yay! We're taking a break. The tissue type, you can have 2 different forms: granulation tissue, and then everything else is necrotic. Okay? Granulation tissue is this beautiful stuff over here. Beautiful red, bubbly, bright, rich in oxygen. When I see this, what phase of healing do you think it is? So, that question tends to appear on boards. What phase of healing is this wound in? Okay. So we're doing a couple of slides like that. So this is skin that's wet. It's called maceration. Okay. So it kind of looks like it's glistening white, and that's because it's excessively wet. What was the other thing that popped up?
Well, I was gonna ask, do they have pictures on the board?
Yeah. Yeah. There's pictures on my exam too. Okay. So it is composed of extracellular matrix capillaries, and what you would say is this is 100% strangulation tissue, right? No, we'll talk about that later. This is just blue bed, tissue type. Now, you do have hypogranulation tissue and hypergranulation tissue. Okay? Most of the time, you're only documenting granulation. Hypo and hyper are abnormal. Okay. But I want you to know how the terms interface sit. For the purposes of our documentation, for worksheet documentation, you don't document hypo or hypergranulation. You only document granulation or necrotic. Okay. Hypogranulation occurs when you don't have enough granulation to fill the wound. So you have a pothole appearance of granulation under your face. There's other pathologies associated with it, like polyamine. Hypergranulation is the opposite, when it fills up above the wound bed. Sometimes it'll fill and then it just keeps filling. Well, skin can't grow up. So usually it has to be surgically excised and then it's usually closed. Now, there's other ways to treat it as well. You just have to recognize that it's present and then there's it's abnormal weakness. Okay. So do it again. Here's the interventions for it. You can also do silver nitrate sticks, which I don't know if you've ever seen them. They're basically look like matches. They have silver nitrate on the end. Cauterize off. You burn off the tissue. That's what you do. You can do it as, depends on where you're licensed to practice and what your practice act states, and what your facility states. In my facility, because I was there for so long, I did advanced surgical training, which is very atypical. So I was trained to use cautery knots, and I had to sign off with the surgeon because I was in the OR with them a lot of times. So I'm at a very bigger skill set than what your normal outpatient does. So if you do any of those things, you really need to make sure you're careful what you're doing. Okay, and then you have necrotic tissue. Necrotic tissue, very bad. It is a breeding ground for bacteria. It is non-viable. What does not grow across non-viable tissue? It's myofibroblasts. Remember, they don't move across them. Right? You've got 2 types. You have slough and you have eschar. Okay. Eschar is historically, we've got other pictures. Slough is here. Eschar is the darker tan brown stuff. The yellow stuff. When you see yellow, you need to make sure to rule out that it's not fat tissue and that it's not fibrin. Fibrinous exudate. Because sometimes they can fool you. Okay. A fantastic picture of slough was, I'll find it. It was there. I'll find it. This one. That's classic slough. Okay, and this one here. Slough is the result of phagocytosis of dead tissue. You're going to document not only the percentage of the necrotic tissue, but also the color of it. So yellow, pale yellow, brown, whatever color it is, then the appearance. So what I mean by appearance is, let's say this is firmly adherent. I can't pull it up. Okay? Loosely adherent means I pull and it keeps moving. Loosely adherent. Okay? It's so much fun. And then you have somewhere in the middle where it's partially adherent and then it locks down. Okay? So you just know if it's firmly adherent or loosely adherent. Okay? Non-adherent means I pull it and it comes right off. Yep.
Are you something like that top one? Are you like taking the Q-tip, digging in with it, or are you using your glove?
In the assessment, I just take my glove and I pull it with my fingers. Yeah. Or if you have forceps, because it's usually pretty slippery. Yep.
Can you point out the S card again?
Yeah, I've got better pictures coming up. Okay. With the S card here, would be here and here. S card is not scab.
Okay.
Don't confuse the two. Okay. Scab is one thing, and it occurs over intact dermal epidermal junctions. It does not occur over full thickness stuff. Okay. So there's the definitions of appearance. Okay? Then you have eschar. Eschar is dead skin and subcutaneous cells. Don't confuse it with scab. Their histology, if you take them apart, they're composed of different things. So scab is composed of blood and serum, and it's over a fresh wound. Okay? Eschar is composed of dead skin, subcutaneous cells, and you see like dead macrophages and a whole bunch of stuff like that, and debris. If you put it under the microscope, they're made of two different things. Again, it can be any color, black, tan, brown, gray, yellow. This is a below knee amputation, okay, up here's the knee. So this is a pressure injury that occurred from an iliac force-fitting prosthetic. Okay, so this was eschar there. This is the same thing that happened after surgery, and they got an infection, and then all the tissue died, and the surgical incision. Again, you document it as saying is it softer? Oh, for adherence, you do the same adherence, the color, the percentage, but then there's something else. You want to know what the stability of the eschar is. And what I mean is, when I push on it, is it solid and firm, or is it mushy? Okay? If it's mushy and cracked, and stuff is pushing out of it when I push on it, that's called boggy or soft. That's not stable. The reason why that differentiation is important is because clinically I treat them differently. If I hit them and it's like touching a phone or a box and it's hard with a metal, it's not giving it all. And when I push on it, nothing comes out from the bottom. That's hard, stable eschar. Clinically, we're going to talk about when do you degrade it and when do you not degrade it, but that comes later. Okay? So there is a differentiation with eschar. So you want to know, is it stable or is it unstable? If there's anything smushy, where things push out when you push on something, something else is going on, usually. And so you usually have to get into that area faster. So this is the posterior leg that you're looking at. This is on an elderly patient, and you can see this is all this is all eschar actually, but you can kind of see how cracked and dry it is. And then you can see the black hard heel ulcer here. You had a really good picture. Yeah, these are great eschar pictures. Can you see that? All just black, hard, apparent. And I've got, anyone who wants to look through more pictures, but now, you remember the hair follicles and how it grows? This is what a real live epithelial patch looks like. They're called epidermal islands that grow out from there. So you would document that in the wound bed, I have 1, 2, 3, 4. Do you see them all? 5, 6, 7. There's a bunch, which is good because it's going to lower my rate of healing. Okay. If you see any other structures in addition to the tissue, then what you would do is you'd identify them. Okay? And what you want to consider is how are you going to protect the structure to keep it alive? And 2, is there anything else that I have to do or alert to anybody? You do not want to dehydrate any live tissue, such as tendons, ligaments, because once they dry out, they're dead and they have to be surgically removed. You cannot fix them again. If you lose the moisture content over them when they're exposed, they're really high risk wounds that you really have to monitor those. So here's what live versus dead tissue looks like. This is a live adipose tissue and an abdominal. This is dead adipose tissue and an abdominal. You see the difference? Bone exposed after a surgical amputation. This is the metatarsal. Healthy is white or tan. Not healthy would be any kind of like, it's like a chippy, kind of like the color of a wall, honestly. And if you also see bone fragments in the wound bed, that's another telltale sign of osteomyelitis. We get more into osteomyelitis then. Then you have, no, that's a you didn't have osteomyelitis. That his other clothes were removed, and I expected to see this. Because this was his day out of surgery. For 2 days, somewhere around there. Then you have tendons. Tendons normally have, remember the peritendon sheath around them? Okay? Usually it's fluid filled. When these are exposed in a wound bed, and same with ligaments, they produce a protective, sloppy looking stuff. It's not dead tissue. It's the body's own way of protecting the tendon and keeping it moist. You don't debride it. You leave it alone. And if you want to know if it's a tendon, move the person's foot or ankle and see what muscles move. Ask the people to contract and then see what's in your wound bed. Very easy way to identify that. These are what they look like when they die. You see the difference? This down here is viable. This is dead. This is the Achilles tendon. Okay. And this is the anterior tibialis. It's dead. Okay. Muscles should look like that. Gorgeous muscles. There's the muscle, there's the tendon, there's the subcutaneous tissue. Okay. And if you don't know if it's a muscle, poke it. It contracts. Okay. Ask them to contract your muscles. And then you have all the other stuff, veins, arteries, and nerves. Okay? So this is the femoral artery down here that's exposed after a femoral bypass, dehiscence or wound opening. This is what a vein looks like feeding. This is subcutaneous tissue that's alive. That's on the medial thigh. And then this is one of the nerves that run through the subcutaneous tissue. So if all of a sudden you hit a nerve, you're going to know because your patient usually jumps. And then you know because you usually can't see them because it blends right in with the rest of the tissue when they're alive. Ooh. I got a good one for you. Yeah. This is my favorite video. My second favorite video. Check this out. This is cool. This is what a blood vessel looks like live. Do you see it?
Oh yeah.
All right.
Yeah.
What is this?
His fingers means
Okay.
someone's toes
Kill the lights.
pulsating.
Oh.
Kill the lights and everybody look. This is in between the first and the second toe. Now watch.
See?
Do you see the beating?
Yeah.
So if you ever want to know if it's an artery, it'll be.
Oh, God.
And it beats all throughout. If it's a small artery or a little artery. Don't hit it. Otherwise you'll get a little.
That's the truth.
Thank you. You can turn the lights on again.
Say, no, you bypass it. So all you do is technically experience it.
Okay. Here's my other beautiful picture. Oh, kill the lights for this one too.
Come on.
This is an external fixator.
This relay?
This is after a gunshot wound. He had 12 gunshot wounds, shattered his entire arm, shattered part of his thorax. This is, I think it was his 8th week in the hospital. Because they finally were able to fix the arm because they had to fix everything else. Okay. And so this X-fix was holding the fragments of the arm together until they could repair it. But they also wanted to protect this region. This is the radial artery. This is the tendon. This is more tendinous sheath. Okay. I forgot all the different. You could see when he moved his hand, you could isolate every single muscle. It was the best anatomy lesson ever. It was the second day I did it. In anatomy. Here we go. So anyways, it's really cool. And he did great. Okay. Then you can also look for sutures and staples. This is open heart surgery. These are the sutures that they use in the open heart surgery. You want to see these nice and closed. These don't come out. They're holding the sternum closed. And then those are just staples. This is after a pop bypass, these exterior strips. You also want to make sure you're not seeing any kind of glass gravel splinters. Okay. You may also hear this term granuloma. And a granuloma is when a massive granulation tissue gets trapped from an infection or inflammation. And so you may hear a granulation formation and then the wound open. That's what they're talking about. Let's just get through your clinical knowledge. This is one of the gentlemen's. This is my lady with an open heart surgery where the sternum to hist, and they had to open it up. And so right here is the heart. This was a gap I was doing. So that one we didn't measure wound depth. Did you understand why? But I did measure the depth over here. So when it's cavity spaces, you don't put anything in the cavity if you don't think you're going to be able to get it down. Drainage wise, generally speaking, drainage is very simple, but your foot goes into it a lot more extension. So the longer I teach this class, even though I made all the terms in the book, there's basically 5 types of drainage. When you see drainage, number 1, how do you rate it? Well, you look at the bandage that came off the patient and you find out when the last bandage was put on the patient. If it was put on in the last 24 hours, then you have a good estimation. If it was put on 4 days ago, you don't have a good estimation until you change it and then you can track it. You typically take off the bandage. So if this was the gauze bandage that I'm pulling out, I will look and see how much percentage of this is saturated. If it's 25%, it's minimal amount. If it's 50%, it's moderate amount. If it's 75% amount, it's a large amount. If it's soaking up raw edges, it's a copious amount. If there's nothing on here, then it could be none or it could be scant. And if there's no drainage, then there's nothing on it, right? So when I typically see nothing on it, but the wound is moist, I know it's scant. It's so small that it's not absorbing onto you. You look at this. So first you see the quantity, then you look and see what the color is. Okay, serous is clear and watery. Then you've got serous. Sanguinous is bloody. Okay. Serous sanguinous is pinkish red, clear, watery. Okay, got it? So serous, sanguinous, serosanguinous. And then you have purulent, which is plus. And then you have a bunch of variations in between that. In general, you can document every wound with either serous, sanguinous, serosanguinous, or purulent, or seropurulent. We'll see. Okay? Those are the main ones. What I don't like about Hannah's book is that she put in so many types of exudate for you. Because the beginner practitioner only needs to know that many. But if you work in it long enough, you need the other terms. So don't get lost in these slides. Here's the major one with the explanations. Purulent is the one you have to be careful of because it implies infection, especially if it's creamy, tan, blue-green. Now, unfortunately, I have a really bad way of comparing wounds to food.
Oh no.
Okay? So I will do my very best to avoid those analogies because I respect like, you need to please not tell me what food is like. Okay, and then here's the definition. Here's the physical definitions of those items. So this is what serous drainage looks like in vivo. This is what sanguinous drainage looks like. Okay. This is serosanguinous. Can you see it? It's kind of pinkish. And it's also going to change based on body type and everything else. Okay. Now, drainage is also termed exudate. However, drainage is a more well-known term. But some clinicians just use exudate, they're talking about the same thing. This is purulence, you see it? The creamy tan stuff dripping down. Now, what I want to show you is kind. Right. When you get to lymphatic drainage, if I were to take, do you know those chemical strips that tell you how much, sometimes they use them for like urine, toxology reports. You can also use them to determine how much protein is in the fluid. They have protein, like basically it's protein sticks. So if I took a protein stick indicator and I put it into serous drainage from a lymphatic vessel versus serous drainage from a wound, the protein content would be much more heavily concentrated in the lymphatics because that's how they return. Okay? So I have serous drainage, but they have a high concentration of large protein. Okay? And then you may also see chyle. Chyle is not purulence. Chyle is from also the lymphatic system. Okay? And it's because of the triglyceride content that's in there. And it's because the cisterna, the different parts of the lymphatic system that are deeper are exposed or broken. And that's where it's coming from. So this is not purulence, this is kind. So when I see this, and I've seen a few, it has a different quality to it. And that's all I'll say. Good job. And then you see this, how it's blue-green hue. Blue-green is only associated with one bacteria, and that is Pseudomonas aeruginosa. Okay. If you see blue-green, it is definitely infected. It's the only book that makes that color of drainage. And it'll stain the tissue. And the drainage will actually have like a green-blue tint. And it also has a very distinct smell. Okay. Fistulas, that's different. Okay, let's talk about odor. Is wound odor normal?
No.
Yes or no?
No.
No. That's the correct answer. No. The wound itself doesn't smell. The tissue does. If there's dead tissue, that smells bad. If there's certain infections, that smells bad. But wounds alone don't smell. They don't typically have a big odor associated with them. Now, body odor does. And cleanliness does. And how long drainage has sat on a sandwich does. So just because you smell odor, don't automatically assume there's something bigger going on. Okay. If you do smell an odor, the right way to handle it is to document present versus absent, and then you clean the odor. These are the ones you have to watch out for. If you walk into a room and there's a putrid smell, if there is putrid, okay, have you ever smelled deer on the side of the road when they've been decompensating, being decomposed?
Wait, you should smell
It's a decompensate. I don't know what that means. Decompensating. Okay. That is the putrid response that smells like dead rotting tissue. And that's what you can smell in some of the wounds for dead rotting tissue. Okay. Proteus smells like ammonia. A proteus infection smells like ammonia. Okay. Or some cat has really gone bad in your house. Okay. And then Pseudomonas has a nauseating sweet smell. Okay. The Puri wound will help to tell you what's going around the immediate edge of the wound. So besides the wound bed, then I'm going to look at the wound edge. And then besides the wound edge, I'm going to look around the immediate skin around the area. And I'm going to talk about the quality of that skin. So what's the color, what's the temperature, what's the texture? This is a neck wound. Okay. He had a cyst removed. And this wound went all the way up 10.5 centimeters above his head on the outside of the skull. Okay. This was leftover infection that was resulting. Okay. So then you start to look for those cardinal signs. Is there any redness? Can you see the erythema that's in here? Okay. When you get to pressure injuries, we'll talk about blanchable versus unblanchable erythema because that helps us stage how deep the pressure is. Okay. It is the ring of erythema in proportion to the size of this wound or out of proportion to the size of the wound? Do you know what I mean? Is it about the same size as the size of the wound, or is it much bigger? If it's much bigger, it's an infection. So whenever you see your erythema green, when you see redness, the redness should be just a small green that goes around the wound, like what's pictured here. On this model here, this is normal erythema. Okay. That goes with the inflammatory phase. If it's huge, border is way out of proportion to that, then maybe something bigger is going on. Here's two legs. Which foot looks different? Right, why? It's blue. What does that mean?
Cyanosis.
Yeah. So this is really bad, especially after peripheral artery disease surgery, because it means that somewhere the arteries are good. Generally speaking. Okay? So hairy wound color, deep red results from the capillary bleeding. Deep tissue is a result of shearing. So you may see anywhere from blue to purple to red along the hairy wound. That's what this says. Okay. You can also see something called hemosiderin staining. That's only associated with venous insufficiency, ulcerations, which we'll talk about later. You can also see ecchymosis or bruising. Ecchymosis is resulting from hemorrhaging underneath the skin, and it causes a bunch of different colors. The other thing that you can see in this picture is extensive ecchymosis along with the hematoma. Okay. You can see the ecchymosis here as well. So that would be ecchymosis. You can also, there's also a grading scale for contusion that you can also use. Okay. You're also looking to see if it's white, is it yellow, associated with deliberate. You can also see the temperature. So when I'm looking at the peri wound, I want to say, okay, this wound has intact integument, this wound has intact integument around the peri wound, but I see a ring of erythema. The other thing too, did I skip it? Which one expiration? Yep, it's gone. No, there it is. Here. I don't know why that got back in the middle. All right, well, those slides should be back more. All right. Here's also, this is, you can have excessively dry skin. You can also have a certain coloration. There's a section that this is the thought I was getting at. This is maceration. This is excessive wetness around the wound. It can either be from position or it can be from the amount of drainage coming out of the wound and it just can't keep up. This is really bad. And the reason why it's really bad is because the maceration area could be an area where this can either extend and now become the whole size of this wound. This will either tear and die, or it will become dry and you can salvage it. Have you ever washed dishes on Thanksgiving and your hands pulled out and they were really, really thin and fragile? Okay. Have you ever cut your skin after that? Okay. So that's kind of the same kind of how this is kind of consistency that this is made up with. Then you also have edema. Now edema, we're going to get into all the differentiation of edema later. So I'm skipping it because the lymphatics are just like that. And they go through what's venous, what's this, what's that, what's that. Okay. Normally, there's another term associated with edema, which is fibrosis. Have you heard that term, fibrosis or inflammation? What does it mean? Heart edema. What does that mean? What's physiologically happening?
Heart because it goes.
No, not hardening of the vessels. So if you have edema because there's fluid that leaks out into the interstitium, right? What typically picks up the stuff that leaks out into the interstitium? The lymphatic system, right? Lymphatic system. So if the interstitial tissue amount becomes so much that it overpowers the lymphatic and venous system, the lymphatic and the venous system, it has nowhere to go. So it hangs out. And the longer it hangs out, the longer those cells don't get a chance to move. And now your immune system starts to fight them. Okay? And then it transitions to a really hard, not golf-like feeling. Like it feels like a golf ball when you feel this stuff. It is really hard, it is excruciatingly painful. You Can get rid of it, but it depends on quality. Okay, so we're talking about measuring of the edge. Wound edge. And after wound edge, we're going to take a break because I see everyone do this. Did you ever think it was this extensive? Alright, so we have the wound. If we look at the median edge, is the edge attached to the wound base or is it unattached? Okay. That's what you're looking at. This is a classic. Can you see the tunnel? Can you see the hole that goes straight down? This goes all the way down to the greater trochanter.
Are you noticing the discoloration?
This discoloration here, okay, well, this is one we have to look at and see who's looking at it. So this discoloration, what do you think it is? Is it open wound or is it not open? It's not open, right. This is what fresh remodeling skin looks like. Okay. And it's always going to be discoloration initially. It's usually a really pale pink or a pale purple that gets laid down. And then through time, you'll start to see the melanin and the pigmentation get back in. So generally speaking, yeah, I usually note it in the period room. But there's a 1 centimeter ring of hypopigmented skin around the area associated with the remodeling phase. That's how we got the plan. Okay. If it is an even punched out look versus an uneven look, these are specific with different etiologies that we're going to learn about. So is the wound edge even, uneven, defined, undefined? Defined means can you know where it starts and where it ends? Or do you not know? Okay. All right. Take a break. You're all free. Come on back in about 10. I put every diagnostic and manual skill you could take into this first lecture. But a lot of the slides that are in there coming up about circulation stuff, they're specific to different etiologies. I will teach you how to do it when we do that lecture, because it'll make more sense in your head of why you're doing this special test for this thing. So, what I wanted to point out is there's a couple more terms in your lecture for the integ integument that define what cirrhosis is, neuritis, all these different frequent things that you'll hear. You can look at those. Then there's a huge circulation slide. And the reason why there's I have a lot of circulation slides in here. And the reason being is because no matter where the hole is, you need to know if there's a blood vessel that feeds it. I don't care if they have a pulse, if the wound is on their foot. The brachial artery doesn't tell me anything about blood flow to their great toe. We need to get specific for it. So what we do is that we have to assess, like if the wound is on my lower leg, what feeds the wound? The wound is here. Which vessel feeds it? So, what artery feeds it? Anterior tib. What vessel feeds it? Are we confident or are we kind of So these slides are really cool, and I finally found that puts it all together. This is from a medical site where they're teaching about what feeds what for physicians. But this is awesome because it puts it all together and it tells you what feeds it on all these slides by organ. So not only do you have the schematic, but you also have this overview. So if I'm talking about anything that's in the pelvis or buttock, I'm going to be referencing over here. If I'm in the arm, if I'm in the leg, what feeds what? Okay. So on the example I just gave you, most likely it's the anterior tibialis. Okay, the tibial artery. Anterior tibial artery. Okay. But what you have to be able to remember is how they kind of divide and where they branch off. Okay, and then I do the same thing for the veins. What is really important is that when you are assessing circulation for your patient, Okay, I'm gonna run you through a big comprehensive exam. I'm just gonna do it all together and I'll show you how to do start to finish with a general rule eval. Because I think that will be helpful when we see all the pieces kind of fit together. Where I start, where I finish. For circulation, cap refill and pulses, okay, fine. I want to physically know if I can hear the arteries. I routinely use a Doppler, which some of you heard during break, which I will show you how to use. The gold standard for knowing if there's a blood flow issue is using an ankle brachial index or an ABI. I'm going to show you how to do that test. Because that will give me a measurement to tell me if they have, depending on what number comes out of that test, tells me if they have a good likelihood or a poor likelihood of healing if it's a lower extremity wound. It is the gold standard for professionals. Then if we think that there is a problem with it, then we refer them to vascular surgery. And then vascular surgery can go in and look at the angios and really find out what the specific problem is. And do ultrasonography and a whole bunch of other cool things. Okay, so let's start with, the other thing that's in this slide are, here's the ABI stuff, because I'll show you that today, how you do it, etc. This is if you don't like math, you can look at the chart. Okay, and then this is also my favorite, which I'll bring back together. But then there's a documentation in gold section in here. And we'll see if we've got time to go to that. Okay. Let's play a game. Kill the lights. Ready for what type of tissue is it? Dun to the dun! Tell me percentage.
100.
What's around the border?
That's sure.
What is all this stuff?
That's cigar.
What is all of this stuff?
What's the weapon?
Skin. Maceration. Healed skin. See the difference? Wet, very warm skin. Healed, very warm skin. Okay? Granulation tissue. Okay. What type of tissue is it?
That's sloth.
Slough? What's this? Eschar. What's this? Yeah, we kind of don't know. Is it bright red?
No.
No, it's like a pale pink, but it's not granulation yet. Okay, so that's what we don't know. We got to clean it up first. What's that? Just like to do stuff like that. Okay. What's this? What's that? Slough.
The
What's this? Eschar.
Looks solid.
Is it stable or unstable?
Stable.
I have to push on it.
Looks
All right, we
stable.
don't know until I can put my hand on it and feel what the integrity is. Generally speaking, if it's whole like this, do you see any erythema around the area? Do you see any swelling? Do you see any other signs that would be kind of like, that doesn't look right to me? Yeah, so most likely it's a stable eschar. What kind of tissue is that?
Muscles.
Yeah, that's a mess. That's a bad That's a mess. This is what an active infection looks like when you pull off a dressing. And you can't tell what's what in the picture. So I can't tell what any of this is right now through the picture. Because it's just a mess. I know it's in the body, but the picture for this one, the day before, I wish I would have saved it. You would not believe the difference. But this is a great infection picture. This looks all dead. This looks like ecchymosis. You see the huge red ring extending, and this is really, really, really hot. Yeah. Oh, sorry. Left buttock. Okay. Here's the buttocks. Here's the head of the patient. What kind of tissue is this? Here's slough. What's this? Eschar. What's this? Slough. Yellow slough. Yes. What's this? You think it's granulation, you see how bloody red it is right there? There are a couple of these.
Granulation.
Well, that's coming. We're not talking about the house. You'll never get me to leave. What's this?
Yeah.
Yeah, what, good question. That's what
Islands.
that is, right? This is a superficial development injury. So what happened was that this person was physically, all their skin physically was lifted off like a glove. And this is the epidermis exposed with the dermal block. So it's a lot of blood right now. Okay. What is this?
That's a mortal combination.
Is that yellow?
That's a mortal combination.
Is it green? Yeah, that's the Pseudomonas stain on top of the slop that's there.
Oh.
Okay. This picture you've seen, this is a transmetatarsal amputation. What is this? Granulation. Isn't that beautiful? I love granulation. It's so pretty. Okay. You see this?
Oscar.
What is that white thing? That's a suture.
Oh.
In case you've never seen a suture. Suture. Look over for surgery. Okay, what's this stuff?
Sloth.
Sloth? What's this stuff?
Oscar.
Eschar. This is above the amputation. This is the medial aspect of the right thigh. Okay. And this is, what is it? It's all sloth. Yeah. Now, the bad part is this little thing right here, this went all the way up to the leg, and I can palpate his pelvis.
Oh.
Yeah, that's delightful, isn't it? Sacrum, head of the patient, flat out. You see the sacrum outline here?
Oh.
Okay, there's the sacrum outline. What kind of tissue is this? Granulation. What kind of tissue is this? Slump. What is this white stuff? Maceration. What is this stuff? Is it intact or not? It's intact. It's hypopigmented skin. That's how you document it. Oh, those are the old Polaroid. When I went to school and I graduated, we used Polaroid pictures. And those are the old Polaroid shots. You can tell the high quality of the camera. Okay. So now let's turn on the lights. Let me show you how you do one. Yeah. Oh, the white border? That's intense powder. Cream. That's what you put on top of that.
I know, yeah.
So we'll talk about all the reasons and that's right. Okay, so after I go through my subjective evaluation,